This is chapter 8, joints. We're going to talk about first the classification of the joints and look into each and individual classification itself, like the fibrous joints, what are the classes under it, the cartilaginous joints, what are the subclasses under it, and then synovial joints. Synovial joint is the most abundantly found or type of joints in our body, and we will be talking about in a bit detail. And then followed by that is homeostatic imbalances. It's going to be really brief, and then we finish it off with developmental aspect. In this chapter, I will be just brushing through certain joints and focusing on other type of joints. So it's mainly the synovial joints where I'm going to pick and choose which joints to focus on, which joints to just keep it brief. The other important things in this chapter is the movement itself. The movements that the joints are capable of doing, you need to know all the names of those movements, the pictures that you're seeing over here, and there are more in your textbook, so we will be going over each and every movement and give an example for each one of those. So why do we need joints? Joints are also called as articulation. Without articulation, we will not be able to move. We have a lot of bones in our body to make that skeletal system. They're all different types, different shapes of bones that we have, and they have to meet together. If there are no joints, cannot move our body. So when these bones come together, they give the skeleton mobility and they hold the skeleton together. If you've ever seen a skeleton in a shop, they actually have screws and nuts and bolts to hold the bones together. Pretty much that's how our joints work. It gives mobility to our skeletal system. The functional classification of joints. Not all joints are made similar in our body. They are different based on how movable they are. In certain areas, you do not want bones to move. Right? In certain areas, like say, for example, between your cranial bones, you do not want them to move. There is no purpose for them to move. Okay, so in that area, it's going to be immovable. So based on the movability, you have three classification in your joints. The first one is called a synarthrosis or immovable joint. Syn means fused together. Arthro means joint. One joint. And that's basically how it is. Immovable joint. And the next type of classification is amphiarthrosis. Amphi means amphibian, where it can live in land and water. It's pretty much like that. Amphiarthrosis, slightly movable. Sometimes it's immovable, sometimes it's mobile. Slightly movable joint. The last one is a freely movable joint, which is found mostly in our body, in most of the joints in our body. It's called as diarthrosis. Diarthrosis is a freely movable joint in our body itself. Next type of classification in your joints are based on what kind of structure holds these bones together. What kind of tissue is used to hold these bones together. There are three classifications once again. The first one is fibrous, the second one is cartilaginous, and the last one is synovial. This is a table that has been put together based on the classification of structure. The first one is a fibrous. It uses collagen fibers to hold the bones and parts of the bones together. It is further divided or subclassed into three: the sutures, syndesmosis, and gymphosis. We're going to talk about them individually later on. Moving from fibrosis, it's cartilaginous joints, which is the bones hold or held together by cartilage. So you have two types again, synchondrosis and symphysis. Remember, chondr means cartilage. And the last one is the synovial joint, which is the freely movable or diarthrotic joints. It actually has a space between the bones and it is encapsulated with articular capsule, and within it has fluid for the free movability in that joint itself. So under these synovial joints, you have plain, hinge, pivot, condylar, saddle, and ball and socket joint. Okay, so these are all the classification that you need to know. We're going to start off with the fibrous joint subclass, which will be the sutures first. Sutures. This is found mostly in your skull. Okay. Sutures. We have talked about that in the previous chapter where we said sutural bones are found between the sutures, right? The sutures between the parietal and parietal, sagittal suture, parietal and frontal, that's your coronal suture, parietal occipital, it's a lambdoid suture, right? So you basically have sutures between these two cranial bones. Now, the reason why you have sutures is because while you're growing, you need that space, you need that mobility initially. But as you get older, these sutures ossify and become synostosis. It's no longer called a suture because it becomes calcified, ossified, hence synostosis. These sutures actually contains connective tissue fibers. So here you can see the sutures. You can see between the two cranial bones, you can see all the sutures between, and these fine, tiny connective tissue holding these bones together. It gives mobility when it is needed. When you are young and brain is growing, you need that. But after that, it just holds it together and completely locks these bones together. Next type of fibrous joint is your syndesmosis. Syndesmosis is held together, bones are held together by ligaments. It depends where these joints are. Sometimes it is movable, slightly movable. Sometimes it's completely immovable. For example, in your tibiofibular joints, between your tibia and fibula, you have your proximal tibiofibular joint and distal tibiofibular joint. Over there, it is synarthrotic. Synarthrotic means immovable joint. But the same type of joint found between your radius and ulna, it is diarthrotic because of the interosseous connection between this. I said supination, pronation, the radius overlap the ulna. That's why you're able to move your palms, right? For that, you need these kind of diarthrotic movements. So you have varying movability in syndesmosis. Okay? So here's a picture of tibiofibular joint that is synarthrotic. The next type of joint that you have is going to be your next type of fibrous joint, gymphosis. Gymphosis is found between your teeth and the alveolar bone of your maxilla and mandible. So you have a fibrous connection between these two bones or teeth and your alveolar margin of your maxilla and mandible. This is actually what we call it as periodontal ligament. This holds your teeth, so you can see those fibers, the white structures right over here. That is your periodontal ligament. So it holds the teeth to your alveolar process or margin of your maxilla and mandible. This is like a peg and socket joint. This be the peg and this is the socket and holds the teeth inside it. That's your gymphosis. Now that finishes your fibrous joint. We're moving on to the cartilaginous joints. Just to remind, there are two types, synchondrosis and symphysis. Synchondrosis is made of hyaline cartilage to unite the bones. Where are you going to see your hyaline cartilage? You're going to see your hyaline cartilage in your epiphyseal plate of your long bones, right? So that's where the multiplication of the hyaline cartilage takes place and the bones try to catch up, ossification tries to catch up, and eventually the plate closes and becomes epiphyseal line, right? So this is a temporary joint that is found in growing young people, right? So it is your epiphyseal plate. Another place that you're going to see is between your ribs. That'll be your first rib and your sternum, and it's going to be immovable. Remember, these two are both immovable joints. The next type of cartilaginous joint you're going to see is your symphysis. Symphysis is the strongest joint that you're going to have. Okay, it is very strong, flexible, amphiarthrotic. That is made of fibrocartilage. Remember, out of all the cartilages, fibrocartilage, the strongest one among all. So that's basically what you're going to see. Now, where are you going to see your symphysis? Pubic symphysis. If you remember from the previous chapter, it's pubic symphysis. Make sure you focus on the spelling. Symphysis, the classification of cartilaginous joints, as ES at the end. Pubic symphysis has IS at the end, completely different word altogether. So pubic symphysis is one area where you're going to see this type of joint. The other place you're going to see this type of joint is between your vertebrae. That'll be your intervertebral disc. Okay, so you have your fibrocartilaginous joints in between the vertebrae itself. So that are the two examples of your symphysis. Now we have finished both the fibrous and the cartilaginous joints and their classification. The last type of joint we have based on the structural classification is your synovial joint. Like I said before, it is a diarthrotic joint. It's found in most limbs. So all your limb joints are going to be of this type of joints. It is going to have a cavity. It's going to be enclosed within a synovial membrane. It's going to have fluid inside. We're going to look at all the structural components of synovial joints in a bit. So this is the most movable joint that you have in your body. Now, before we go any further about the classification of synovial joints, let's look at the distinguishing features. I said it has a cavity. This cavity is called as synovial cavity. The bones itself does not sit upon each other. So when you were looking at the other type of joints, you saw that the bones were really, really close together. The parts of the bones were really close together, right? But that is not going to be the case in your synovial joint. So you have one bone over here and you have the other bone over here, okay? And here's your capsule that covers the space, and it is lined by synovial membrane, right? Another membrane that goes along. Now, this joint cavity, this whole area where it is enclosed by the synovial membrane and the capsule, is what we call it as synovial cavity. Okay. The bones that actually are part of this type of joint, where it is encapsulated, it is covered by a thin hyaline cartilage itself. So you have a thin hyaline cartilage on top of the bones that actually are found within this joint. So that is called as articular cartilage. Okay. So within this bone, I said it has a capsule right over here. It's a thick capsule that makes sure that when you move your joint, it doesn't open up, right? It keeps it enclosed. So that is basically articular capsule. The membrane that is found within this capsule, within this cavity, actually helps to produce a fluid. So you're going to have fluid inside the cavity all over, right? You're going to have fluid all over this area. Fluid helps to make sure that when you move this joint, keeps the bones from rubbing against each other. You do have the articular cartilage lining the bones itself, but another preventive mechanism so that you don't have friction is this fluid that is created or secreted by your synovial membrane itself. So you have, let's just focus on that. You have the capsule, which has two layers. You have the outer fibrous capsule and you have inner synovial membrane, which is a loose connective tissue. And you have synovial fluid, which is produced by your synovial membrane, which gives that lubricant effect to the bone itself. Now here's a better picture of general synovial joint. Okay, so the blue stuff that you're seeing is the hyaline cartilage that lines the bones that meet in this joint. The green stuff that you're seeing over here is your synovial membrane itself, and that is the one that produces the fluid that fills this space in here. And then you have the white layer right over here. That'll be your fibrous capsule of your articular capsule itself. So your articular capsule is made of two. One synovial inside, outermost is the fibrous capsule. And this one that you're seeing over here is a ligament that stabilizes your entire joint. Apart from the capsule, it's not enough protection against the movable. Remember, these joints are freely movable. That means it is prone to many kind of tears and slips and all those things. So it is reinforced by the ligaments around, right? So you have a lot of ligaments going around your synovial joint to reinforce this entire joint. Now, this is the ligament that I was talking about. You have your three types of ligaments that encloses your capsule itself. The capsular, which is part of your capsule, the extracapsular, which is outside the capsule, and within the capsule is intracapsular. It is covered by the synovial membrane. So when you look at this over here, so sometimes you have, this will be the extra capsular, this is the capsular, and within that you might have some fibrous tissue over here, like in your knee joint you have intracapsular ligaments. The next distinguishing feature, it is rich in blood supply and nerve supply. Remember, the synovial membrane is making the fluid. Where is the nutrients to make that fluid comes from? From blood. So it has rich supply of blood, but the blood vessels itself is not found within the capsule. So if you look at this picture over here, you're not going to have blood vessels in this area. It's going to be around the capsule itself, okay? Because you don't want the blood vessels between the joints, okay? So it is found, capillary beds are found in the synovial capsule. Nerve fibers, why do you need nerve fibers? So you do not overstretch that joint. It is a freely movable joint. It is a diarthrotic joint. So that means you are prone to move the joint in a direction where it is not supposed to move, right? So that is the reason why you have a lot of nerve fibers to detect the movement, to detect the position, and all those things. So these are the 6 distinguishing features that you have within your synovial joints. Moving on. Apart from all the features that we talked about in the synovial joints, you do have extra reinforcement found in certain joints, right? These reinforcements, there are 2 types that I want you to remember, mainly the definitions. One is called as bursa and the other one is called as tendinous sheath. Now, if you look at this picture, you see this green stuff over here, right? So you have the ligament. The ligament is right over here. Here's the articular cartilage, the hyaline cartilage resting on top of the bone. And in between that, you have a sac of synovial membrane within which you have the synovial fluid. This sac is what we call it as bursa. It acts as ball bearings between the ligament and the bone itself, the articular surface of the bone. It makes sure that the ligaments that are reinforcing the joint does not rub against each other and produce friction, which produce heat. Okay, so as the joint is moving, the bursa rolls and lessens the friction in that particular joint. The other type of friction reducing structure that you have is tendon sheath. It's pretty much like the bursa, except it covers the entire tendon that goes and reinforces that joint. So here you have a tendon that's coming out from the joint, and you can see that the tendon sheath is enveloping like a hot dog bun, right? So this will be the hot dog and this is the bun around it. So the tendon sheath is the bun and it covers the tendon that comes out of that joint. Again, reducing the friction between the 2 tendons, 2 ligament tendons. And that is basically also, tendon sheath is also made of synovial membrane, which contains synovial fluid in it. So these are the extra structures that actually reinforces and make sure that you do not produce friction. Why is it so important to reduce friction in a joint? Because when you have friction, heat is produced. When heat is produced, the cells that are around it dies. That means when the cells die, debris is formed and the bone starts rubbing against each other, which produces more friction. That is exactly what happens when we get older. Okay, that's why we have knee joint and all the other joints starts aching, because these reinforcements are not there anymore. Let's talk about movement of the synovial joint itself. For you to move a joint, you need to move your bone. For your bone to move, you need to contract your muscle. That is the basis of every movement, right? So the muscle attachment determines which direction the joint is going to move. A muscle has two attachments to your skeleton. One is the origin of the muscle, which is usually it attaches to the immovable bone. And then the other one is the insertion, where it attaches to the bone that it requires it to move. Say, for example, your deltoid muscle. The deltoid is attached to your girdle and then goes all the way to your humerus, deltoid tuberosity of your humerus, and the diaphysis in the shaft of the humerus, right? When you move your deltoid muscle, your humerus is the one that moves, right? So that means the origin is going to be in the girdle for the deltoid muscle, and the insertion is going to be in your movable bone, which is the humerus. Okay, so each muscle has an origin and insertion, and this plays an important role how the movements are done in that particular joints. When a joint moves, it usually occurs along certain planes. It moves along the transverse, frontal, or sagittal plane. Okay, based on how the attachment and origin is, it moves along these three planes. Okay, so that's basically what we're going to talk about. The range of motions of your synovial joint: non-axial, uniaxial, biaxial, and multiaxial. Meaning, in a non-axial range of motion, it is just slipping. What is slipping? The bone is just slipping against each other, and there is no movement in any plane. Whereas your uniaxial, there's a movement along one direction, one plane only. Okay, biaxial, you have movement in two planes, and multiaxial, movement in all the three planes. That'll be your transverse, that'll be your sagittal, that'll be your frontal plane. So based on which plane the joints move, you have these classification: non-axial, uniaxial, biaxial, and multi-axial. There is a table in your book that tells all the joints, that describes all the joints and what kind of joint is found in that area and what kind of movement is there in that area. I'm not going to go through that, so you don't need to know all those joint names and which articulating bones and classification and movement. You don't have to know all those things. So instead, we're going to move forward with the synovial joints and look into more of the movements of the synovial joints. The first one is a gliding. This is where I said it is just a sliding or slipping movement. It doesn't occur in any plane. The next one is an angular movement in an angle. So that'll be uniaxial. So that's going to be flexion, extension, hyperextension, abduction, adduction, circumduction. The third one, rotation, is medial and lateral rotation, goes along all three planes. First, you have the special movements, which is supination, pronation, dorsiflexion, plantar flexion of the foot, inversion, eversion, protraction, retraction, elevation, depression, and opposition. You need to know all these movements and example for all these movements. You have a beautiful range of pictures in your text. So this is gliding, where your wrist bones, that's your carpals, they slide among each other when you move your wrist. When you wave, you're actually doing gliding movement at your wrist. So that's basically gliding movement. That is non-axial. Angular movement, it decreases or increases an angle. That'll be your flexion, where you decrease the angle of the joint. Extension, where you increase the angle of your joint. Hyperextension, you're going beyond your normal range of movement. Okay, the classic example will be your head. Flexion is bending down your head towards your thoracic region. Extension is keeping your head straight. Whereas if you go behind, it'll be your hyperextension. The same you can do with your vertebral column too. Flexion is bending down, extension is standing up straight, hyperextension is leaning backwards. Okay, your extension and flexion can be done in your knee joint. So you have your flexion, shoulder joint. You have, this is a picture of shoulder joint. So flexion is moving your arms forward, extension is moving your arms backward. Whereas in your knee joint, flexion is lifting your foot towards your back, An extension is standing straight. That's an extension for your knee joint. If you're talking about your elbow joint, then flexion is when you bring your forearm close to your arm, to your shoulder. And then extension is basically letting your arm straight. Okay, so those are the examples of flexion, extension, and hyperextension. Then we move on to abduction and adduction. Okay, adduction. Adduction is when you move your limbs towards the midline. You're moving it close to your midline, that's adduction. If you move it away from the midline, it is abduction, abduction, okay? Adduction is towards the midline, ab away from the midline. Circumduction is basically all of this together. Flexion, abduction, extension, adduction, all together make the circle cone-like movement in the space is circumduction. Rotation. Rotation is around its own axis. Remember I said atlas and axis? Axis has a pointy structure that goes in the posterior end of your atlas. It's called as dens. So that basically is rotation. And it also have rotation of your humerus. Let me see if I can show. So here, you're shaking your head, that's rotation. And if you move your femur, that's rotation. And if you go laterally, it's lateral rotation. If you move it medially, it's medial rotation. Supination and pronation. This happens only in between your radius and ulna. Supination is in the anatomical position of your body. So that'll be palms facing forward, that's supination. But if you turn it backwards, dorsally, that over here is pronation. Because the radius, you can see how the radius crosses over the ulna, rotates over the ulna. This is pronation. This is the reason why we don't consider palms facing backwards as not an anatomical position, because your bones are not in normal position when you pronate. Okay, so that's why you have to have palms facing forward when you talk about anatomical position, because the bones are aligned normally. Okay, so here's your pronation and supination. Next special movement that we're going to talk about is dorsiflexion and plantar flexion. Dorsal part of your foot is this area, and the plantar part is your sole of your foot. So if you flex your foot towards the dorsal part of your foot, it's dorsiflexion. And if you flex your foot towards the sole of your foot, it's plantar flexion of your foot. The next special movements in your foot is inversion and eversion. Inversion is when you move your foot towards the midline. Okay, so the lateral part is facing the floor and your big toe is facing upwards. So that'll be inversion. Eversion is when your big toe area, the medial part of your foot, is facing the floor and the lateral part is facing upwards. Eversion. Okay, so this is also found in your foot. The next type of movement that we have is protraction, retraction. Protraction is pulling it outward like a drawer, right? So you are moving it outward. So that's protraction. Example over here is your mandible joint. And the retraction is pulling it, pushing the drawer back inside, retraction of the mandible. The next mandible movement that you can have is elevation and depression. Depression is when you open your mouth, the mandible drops down. Elevation is when you have normal position of your mandible. The only special movements that we have is the opposition of the thumb. Okay, that is the most important movement that we have as an ape actually. So you have opposition where your thumb can meet your fingers. Thumb touches the tip of your other fingers, that's opposition. Okay, so this concludes all the movements. You need to know examples for all the movements. Keep your name straight and practice a lot. Now we're moving on to classification of synovial joints. We know the structure, the characteristics of synovial joints. We know the movements that are there. We know all the planes that moves in. And now we're moving on to the classification. plain, hinge, pivot, condyloid, saddle, and ball and socket. All these types are based on what kind of surface, articular surface, do those bones that meet together have. So when you look at plain, it's non-axial movement. The bones that meet together in this particular joint are flat, hence only gliding movement are possible. Like we said, gliding movement of your carpal bones when you wave, that is a plain joint, and it also is a non-axial joint, and it gives the gliding movement itself. The next one is a hinge joint, moves like in one angle, reducing the angle or increasing the angle. So this will be flexion and extension. This is what I said about the elbow joint. You have one particular bone that forms the joint that actually sits on the other bone that forms the joint. So here you have the trochlea of the humerus that we already talked about that sits on the trochlear notch of your ulna. Hence, the elbow joint, the hinge joint is possible. Okay. The next type of movement or joints that we have is your pivot joint. Pivot joint is when you have a sleeve around one bone that comes from the other bone. It is also a uniaxial joint. So here you have your ulna and here is your radius. So from your ulna, you have a sleeve that goes around the radius, head of the radius, and keeps the head of the radius in position. And the radius within that sleeve twists and turns, right? So this is a uniaxial joint, okay? So that is your pivoting one. And the next one is condyloid joint. Condyloid is biaxial joint. So here you have both the surface of the bones are pretty much oval. So where are you going to see that? You're going to see that where you have metacarpophalangeal joint. So here's a metacarpal bone and here's a phalanx bone. So between those two you have your condyloid joint. Both the surfaces are oval in shape. Saddle joint. This allows great freedom and movement in this particular joint. One surface is convex, the other one is concave. So here you have your thumb, okay, between the carpal and metacarpal joint of your thumb. That's why you're able to do opposition in your thumb joint. Ball and socket is just that. One surface is ball-like structure and the other surface is socket-like structure. Ball and socket over here is a shoulder joint, but you can also give an example as pelvic and femur joint as well. Okay, that is also considered as ball and socket joint. So here we're finishing all the classification of your synovial joint, and we're going to move on to one particular type of joint. So we're going to discuss about the knee joint, which is the most important joint that I'm going to focus on in this chapter. Knee joint is the largest joint that you have in your body because this is the joint that actually bears your entire body weight. So that means it has to be reinforced by a lot of ligaments, right? And you have a lot of reinforcement. The C-shaped lateral and medial menisci. These are semilunar cartilage that are found between the femur and tibia. Remember, your knee joint is made of your femur, your tibia, and your patella. You have your femoropatellar joint. The patella sits right on top of the patellar surface of your femur, and it helps to glide when you are flexing your knee. The femorotibial joint is tibiofemoral joint is between the femoral condyles and your condyles of your tibia, okay? And between these two bones, you have the C-shaped extra reinforcement that is found. It's the semilunar cartilage. It helps flexion, extension, and some rotation of your knee. So here is a lateral view or sagittal section of your knee joint. Okay, so when you look at this, you can see how complex this whole knee joint is. So you're going to have a lot of reinforcement. So you have your reinforcement over here, that's a bursa. You have a reinforcement over here on top of the patella so your skin doesn't rub. You have reinforcement over here of the patella. You have some fat going on that also helps to lubricate. you have a nice big space over here inside your capsule, and then you have the C-shaped menisci. So I keep telling C-shaped menisci, right? So how does that going to look? It's going to be like this. Okay, on top of your tibia, you're going to have your lateral menisci, because this is anterior. This will be lateral over here. And then you have your medial menisci. And this will be the cartilage that covers your tibia. That'll be the hyaline cartilage. Articular cartilage is covering your tibia. So these two menisci, if you have ever followed the sports injury, this is basically what they're talking about, medial meniscus and lateral meniscus. So these two meniscus actually helps the bone, protects the bone from rubbing against each other, protects the femur from rubbing against your tibia. So let's go back to this picture over here. Now, if you remember from the characteristics of your synovial joint, I said there are a lot of ligaments that reinforce. You have your extracapsular, you have your intracapsular, and you have your capsular ligaments itself. So that's exactly what you're seeing. Here's your articular capsule. That's the capsular. Here's your intracapsular within the capsule. And here will be your extracapsular. Okay. So outside the capsule. So let's look at more of them in detail. So for our sake, you need to know all the major ones. So you need to know that your femur and your tibia and fibula are also connected. So you have your fibular collateral ligament on your lateral side and tibial collateral ligament on the medial side. From your quadriceps muscle, you have your tendon of quadriceps of the femoris muscle attaching to the patella. From the patella, you have your patellar ligament attaching to the tibial tuberosity over here. Okay, so basically when you move your quadriceps, you're going to move your tibia because of how it is attached. Apart from the collateral ligament on the lateral and medial side, you have your patellar lateral retinaculum and medial patellar retinaculum. So all these ligaments reinforces your knee joint itself. Let's look at more of them. So over here, you can see how you have your tibial collateral ligament, like I said, and then you have your fibular collateral ligament on this side. This is your posterior view, hence the fibula is towards the lateral. So, and then you have a bunch of other ligaments from other muscles forming a extensive support system in your knee. We're not going to talk about all the other ligaments that are there. All I want you to focus is the tibial and fibular collateral ligament, and as well as the retinaculum, patellar retinaculum, patellar ligament, quadriceps, tendon of your knee joint. Now let's look at the joint itself carefully. So those are all were extracapsular ligament. Okay, capsular ligament, we already know what it is. It just encloses the entire space cavity. Now let's look at the intracapsular ligament within the capsule. So here you have your anterior cruciate ligament, and you have your posterior cruciate ligament over here. Okay, so these two are the other ones that you need to remember: a medial meniscus, lateral meniscus over here. Okay, so here fibular collateral and then tibial collateral. So all the stuff that I have marked over here, you need to know. Okay, so you need to know lateral meniscus, medial meniscus, patellar ligament, quadriceps tendon. You have your posterior cruciate ligament, anterior cruciate ligament, fibular collateral ligament, tibial collateral ligament. There are 3 C's that you need to know. 3 C's. The 3 C's are the cartilage, that'll be your meniscus, lateral and medial, 1 C. Second C is your collateral ligament, fibular and tibial. Third C is your cruciate ligament, posterior and anterior. 3 C's are very important in your knee joint. Okay, so when you have either one of these broken, that's when you have a problem with your knee joint itself. Okay, let's look at this picture. This is a picture where you have lateral blow. Because the blow is lateral, it displaces everything medially. So that means it breaks the tibial collateral ligament, it breaks the medial meniscus, and it breaks the anterior cruciate ligament. ACL. Remember ACL? A lot of sports injury involves ACL, medial meniscus tear, tibial collateral ligament tear as well. This is what happens when you have lateral blow. Everything shifts medially and breaks everything medially. Okay, so this is the reason why you need to know 3 C's. Your cartilage, that's your meniscus, your cruciate ligament, anterior and posterior, and your collateral ligament, tibial and fibular. Okay, so this concludes your knee joint. Let's move on to your shoulder joint. Shoulder joint is the most movable joint that you have. Okay, because there's so much freedom of movement, it compromises its stability. If you remember from your scapula, we talked about the glenoid cavity. Glenoid cavity that is found in the scapula is very, very shallow. Okay, so that's right over here. You can see the head of the humerus sits on here's the head of the humerus, and here's the glenoid cavity. And you see how shallow it is? It doesn't even cover the entire head of the humerus. This actually makes sure that we are able to move our arm freely. Because we have so much freedom, the stability is being compromised in this particular joint, in your shoulder joints. So what does it require to make sure that at least it is somewhat stable? For it to make it somewhat stable, it has a lot of reinforcement going on. You must have heard of rotator cuff injury, right? What is rotator cuff? Rotator cuff are nothing but tendons that encircle your joints. Subscapularis, supraspinatus, infraspinatus, and teres minor. These 4 muscles and their tendons encircle the shoulder joints so that it is kind of reinforced. The whole shoulder joint is kind of reinforced. When you talk about rotator cuff injury, you're talking about injuries to these tendons, either subscapularis, supraspinatus, or infraspinatus, or teres minor, tendons that are injured. So in the next picture, you can see how all these tendons actually reinforces. The other type of ligament that you need to know is the articular capsule by glenohumeral ligament that encircles the whole thing along with the head of the humerus, the glenoid cavity, everything is encircled by this ligament. And then you have of the glenoid cavity is enhanced by glenoid labrum. Labrum means lip. Okay, so here's the actual glenoid cavities covered by hyaline cartilage. That's your articular cartilage. And then surrounding that, you have right over here, you have the glenoid labrum. And here are your glenohumeral ligaments, the articular capsule that surrounds the entire cavity itself. So glenoid labrum kind of gives a depth to your glenoid cavity. So it makes it a little bit deeper. So that's basically what's a function of glenoid labrum. So under your shoulder joint, you need to know that your glenoid cavity and your head of the humerus, those are the 2 bones that forms the joint. Because your stability has been compromised, it gives more freedom. The glenoid cavity is a bit enhanced with the help of glenoid labrum. Surrounding that is your articular capsule, that'll be your glenohumeral ligament. Your entire joint is reinforced by rotator cuff, which includes subscapularis, infraspinatus, supraspinatus, and teres minor tendons. Okay, that's all you need to know in your shoulder joint. Moving on to your elbow joint. Elbow joint is made between the 3 bones, radius, ulna, and humerus. Your ulna has 2 processes. Anteriorly, it has your coronoid process. Posteriorly, it has your olecranon process. And in between these 2 processes, you have your trochlear notch. So here's your coronoid process right over here. And here's your olecranon process over here. Okay. So you have these 2 processes, anteriorly and posteriorly. In between, you have trochlear notch. Trochlear knot sits on the trochlea of your humerus. The olecranon process goes to the olecranon fossa of your humerus. The coronoid process goes to the coronoid fossa of your humerus anteriorly. So this actually gives the hinge movement that you have. Okay, your elbow joint is reinforced by ligaments, of course. Apart from the articular capsule that you're seeing like a silvery shade over here, that'll be your articular capsule. You have your collateral ligaments, radial collateral ligaments on the lateral side, and you have your, on the medial side, you have your ulnar collateral ligament on the medial side over here. Okay, so these two are the only ones that you have stabilizing this joint. Between your humerus and your radius, remember the radius, the head of the radius sits on the capitulum of the humerus, and then you have your radial fossa in your humerus. So from the ulna to your radius, there is a sleeve. That's your annular ligament that causes the pivoting movement within, right? So that is the only ligament that reinforces your ulna and your radius joint going on over there. And because of that, it is easy for the radius to get dislocated. This is all that you need to know in your elbow joint. I'm going to move on to the hip joint. The hip joint is also a ball and socket joint. And the importance of your hip joint is that it is so stable, okay? Because it is stable, it is limited. The motion is limited by the deep socket. The acetabulum, remember acetabulum from your hip bone, it's made of all three bones, ilium, ischium, and pubis. The head of the femur sits in the acetabulum, and the acetabulum is so deep that the motion is not as much as your shoulder joint. Okay, it's fine because your body weight is resting on that joint, so you need to have a bit of stability over here. Okay, even though the acetabulum is nice and deep, the depth is further increased by, again, the labrum, the acetabular labrum that you see over here and over here. Okay, so the bone stops over here, right? And the actual depth of the acetabula is increased by acetabular labrum. Okay? And you can see the articular capsule surrounding the entire joint over here. Within the capsule, just like your ACL and your PCL, you do have within the capsule a ligament that attaches the head of the femur to the acetabulum. That'll be over here. That's called as ligamentum teres. What other ligaments reinforce your hip joint? The ligaments that reinforce your hip joint are ligaments that connect your femur to your hip bone. So it'll be your iliofemoral ligament, pubofemoral ligament, ischiofemoral ligament, and from the head of the femur to the acetabulum, which is the ligamentum teres, which we just talked about. So in this picture, you can see your iliofemoral ligament and ischiofemoral ligament over here and over here. Okay, and in the next picture, you will see all the others. So you're going to see your iliofemoral and as well as a pubofemoral ligament. So these are all the ligaments that reinforces your hip joint. So when they're doing any kind of hip surgery or knee surgery, they're actually going through these ligaments. Okay, so they're removing these ligaments, cutting off the head of the femur, smoothing out the acetabula of your hip bone and replacing it with prosthetics, right? That's exactly what they're doing when they're going and fixing your joints. The same thing for your knee joint as well. They cut off the condyles of the femur, they cut off the condyles of the tibia and replace it with prosthetics. Okay, so that concludes your hip joint. We're moving on to your TMJ or temporomandibular joint. If you remember from your bone, I said the mandibular condyle and the mandibular fossa of your temporal bone forms this joint. So here is your mandibular fossa right over here, and here's the mandibular condyle of your mandible. So these two forms the joint. It is not a strongly reinforced joint because you need to move your jaw for speaking, for eating. So these are not reinforced as much. Because they're not reinforced as much, it is prone to slipping. Okay, so here you can see your articular cartilage and you have your lateral ligament, and that's all you have under your TMJ. So this concludes all the joints that you need to know. Now we're moving on to homeostatic imbalances of your joints. We're starting off with common joint injury. That'll be your sprain and cartilage tear. Remember, these are all cartilages, hence only partial tears can be able to repair themselves, but it is going to be slow. But if it is more intensive, they cannot repair itself. You need to have surgery because there are no blood vessels. There is no regenerative capacity in these type of tissue. Okay. Cartilage tears are usually due to compression and stress. When the fragments are there within the joint, it causes the joint to lock or bind. So that's basically what we call as lockjaw and all those things, right? And it has to be repaired arthroscopically. So here you can see your toe and meniscus. They have to go in through arthroscopically and repair that area. Dislocation is also called as luxation. This is when you have the bones within the joint out of alignment. Okay, of course, when the bones are out of alignment, you end up having sprain or inflammation or joint immobilization. Okay, and subluxation is partial dislocation of a joint. The other type of homeostatic imbalances usually are inflammatory and degenerative in condition, meaning they're going to cause tissue damage. We're going to start off with bursitis and tendinitis. This is the bursa that actually helps to reduce friction. That one is inflamed. Now, because of increased motion, you end up having these problems. Okay, tendinitis, mainly it's overuse. Arthritis is the next big topic. Arthritis, as we know of, is very common. That's old age and you get arthritis. But there are actually 100 and more different types of arthritis caused by different etiology. It might be because of bacteria, it can be because of virus, it can be because of autoimmune disease. There are a lot of reasons that you can get arthritis. Okay. If it is acute, it's usually bacteria. You can give antibiotics. If it is chronic, then it's usually rheumatoid arthritis, osteoarthritis, or gouty arthritis. So these are all the different arthritis, but we're going to focus on three main types. So starting with the osteoarthritis, which is the most common type of arthritis that we have because of aging or prolonging our life expectancy. And also because of obesity. Because of all those things, you end up having osteoarthritis. It's a normal aging process. Because of all the weight that we put on your knee, they start to rub against each other as you get older, loses the menisci, loses the fluid, lubricant that is within, and your bone starts rubbing. Once the bone starts rubbing, it starts thickening up and produces pointy bone structures called as bone spurs, which worsens the condition and restricts the movement considerably. What do you do? First, you have to stop the pain. When the bone starts rubbing against each other, pain is going to be overwhelming. So you have to stop the pain. After that, you have to stop the inflammation, right? And also helps if you do physiotherapy. Recently, I saw an article how most of the knee surgery that are done in the osteoarthritic patients are actually not that effective. Physiotherapy seems to be more effective than knee surgeries. Okay, so physiotherapy is one of the things that we can do when you have osteoarthritis. The next type of arthritis is rheumatoid arthritis, which is autoimmune. It affects young people to old people. It is a chronic inflammatory condition, autoimmune disease. This one that we're talking about is when it happens in older people between age 40 and 50. The symptoms are just the same, except unlike osteoarthritis where you might have just one knee pain, Rheumatoid arthritis, because it is autoimmune, you usually have bilateral joint pain, bilateral condition. So you're going to have that effect in both the joints of your limbs. Okay. This might also lead, because it's autoimmune disease, it might also lead to other cardiovascular problems in your body. Osteoarthritis, how do you distinguish this from the osteoarthritis? Rheumatoid arthritis have some clear symptoms. Okay, first off, RA is found bilateral. And then when you look at the x-ray, you can see that synovial membrane has thickened and it forms something called as pannus. Pannus actually erodes the cartilage and forms the joints from joining together. So here you have your pannus, and you can see over here the joints have already, the wounds have joined together completely. There is no space that you see like in these joints. So you have the pannus over here and they're joined together. This is also a classic symptom that happens in rheumatoid arthritis. You have an ulnar deviation. Because of all the pannus that is being formed, the joint automatically moves towards the ulnar. Here's your thumb and here's your little finger. You can see an ulnar deviation going on in osteoarthritic patients. Treatment for it, because it is autoimmune, usually they're trying to suppress the immune system that attacks your joints. So you end up giving immune suppressants when it is too progressive, right? When you're just starting with the treatment, you usually give the similar treatment as in osteoarthritic patients, like aspirin and other physiotherapy and other anti-inflammatory drugs. You do have newer modifier drugs that neutralizes your inflammatory chemicals being used in rheumatoid arthritis. The next type of arthritis is gouty arthritis, usually found in men, and this is due to uric acid crystals. The body is not able to clear the uric acid, and the uric acid is found too much in the blood and it starts depositing inside the joints. These crystals hinders the joint movement, causes inflammation in the joint, and immobilizes the joints eventually. Okay, if you do not treat it, the bone end fuses and immobilizes the joint. It is very simple treatment. You take a lot of water, stop drinking alcohol, stop eating meat because there's a lot of purines in meat products, and that'll reduce the uric crystal formation in your body, and that'll actually help the gouty arthritis. And also there are some drugs that actually are used in gout, but they do have their own complications. So it is better to reduce it with food and drinking plenty of water initially. If it gets worsened, then you resort to drugs. The next type of arthritis that we have are caused because of bacteria. Lyme disease. Lyme disease has different symptoms, but one of the symptoms is actually joint pain and arthritis. Because it is a bacteria and it's been transmitted by tick bites, it can be easily treated by antibiotics. So these are all the different types of arthritis that we have. Homeostatic imbalances. Keep it simple. Just go over it briefly. The last part of your chapter 8 is your developmental aspects. By week 8, your synovial joint resembles adult. The joint size, flexibility are modified by use. So as you use your joint, you tend to modify your joint size, shape, and flexibility as well. And that is basically why if you start working out or doing ballet or any kind of gymnasium, younger age, you have more flexibility compared to you taking up a ballet or gymnasium after an older age. Or the same goes with practicing yoga. If you practice yoga continuously, you're getting more and more flexible, but when you stop, you go back to the original flexibility. But as you get older, because of abuse, you are going to take, the joints are going to take toll. But remember, if you don't use it, you lose it. That is basically how the joint is. Overusing as well causes damage to your joint. So runner's knee, right? That's because of overusing it. As you get older, ligaments, tendons shorten and weaken. Intervertebral discs become thinner and likely herniate. And these all happens after age 70, you also end up having OA, which is osteoarthritis. As I said, more lifelong expectancy is increased, and that actually hurts your joints. Okay. Exercise always protects your joints to an extent, but if you overdo it, of course, it's going to harm it as well. This actually completes your chapter